representative images, but here you can see that the liver is brighter than the spleen, not only on the T1 image, but also on the T2 weighted image. And on this opposed phase image, and in also the fat suppressed image, this patient has so much fat in the liver that you can actually see drop in signal even on the fat suppressed image. So that's the degree of problem that we face. When you have NASH or other forms of hepatitis, you will see a common finding, which is periportal and pericholecystic edema. So here's a patient. These are T2 weighted scans without and with fat suppression. The opposed phase T1 weighted scan, the FST1, which in my personal opinion is my most favoritist sequence. And then you have the MRCP projection again. And the MRCP projection demonstrates beautifully the periportal and the pericholecystic edema. If you have this as a single image, you can make a diagnosis of hepatitis in this patient. The reason why I'm saying this is more than hepatitis and it is steatohepatitis is that this patient also has a reduced signal on the opposed phase scan. So here's a patient who actually has active NASH going on in his body. The other thing which you see is that these are the sequential diffusion weighted scans. Now, in my opinion, the diffusion weighted scans don't necessarily contribute too much to focal malignant versus benign lesions very often. But if you have a patient with hepatitis, occasionally you will see that as the B value increases, so does the signal of the liver. Normally, any normal structure will show a suppression in signal as the B value is increased. So this is a normal liver. You can see that the liver becomes darker on the higher B values, and of course there is no periportal edema in this patient. Now this is one of the uses of MR, and that is that you can actually distinguish cirrhosis, hemocirrhosis and hemochromatosis by doing one sequence, which is the in and opposed phase T1 weighted scans.